We welcome you to our webinar, which is part of a series of that we have planned. And this one is entitled Building Stronger Health Systems in Sub-Saharan Africa, Patient-Centered Care and Multi-Disease Integration. We want to share our experiences and lessons learned collectively to focus on eliminating TB and addressing other public health issues. I will start off with an introduction, and we'll have a keynote address from the director of our organization, the KNCV Tuberculosis Plus Foundation, and then we'll have another opening keynote from Obert Kachuade from the Global Fund. Following that, we will have a setting the scene talk from WHO Africa, Dr. Jean Dudu Irekhena. And we will have 3 country experience presentations. The first one from the Democratic Republic of Congo. And he will speak in French. The slides will be in English. And we will have a translator. She wanted to state she's not a professional translator, summarizing each of the slides for you in English. Followed by that, we will have a presentation from Uganda and from Nigeria. Then we will have questions and answers and some closing remarks. In between the introduction and the opening remarks, we'll ask you to answer a question with 1 or 2 words in the chat. And we will repeat this after the country experience talks. And we will build, based on your answers, what we call a word cloud that collectively shows what you've written in the chat. So without further ado, I'd like to invite our first after I give a short bio, which I will give of all the speakers. I will invite our first keynote speaker, Guirado, to present. So Mustafa Guirado has over 25 years of experience in improving public health outcomes in TB, TB-HIV, drug-resistant TB, leprosy, in a variety of healthcare settings, from the healthcare facility to the national and the global levels. He has extensive know-how in program design, planning, implementation, monitoring, and translating science into practice. Previously, he was a deputy director of the Federal Ministry of Health in Nigeria and has had a progressive career with KNCV Tuberculosis Foundation. He is currently our executive director of the Global KNCV Tuberculosis Foundation based in The Hague. Without further ado, Guirado, I would like to ask you to give the first keynote. Thank you.
Thank you very much, Gerard, and thanks to all the colleagues for pulling these programs together. Colleagues, good morning, afternoon, and evening, depending on where we are at the moment. It is my sincere pleasure to welcome you all to this important webinar, Building Strong Health System in the Sub-Saharan Africa, Patient-Centered Care and the Multi-Disease Integration Platforms. Of course, we are all aware that across our region, health system faces significant challenges, but today's discussion is really about solutions. Therefore, permit me to just point out some areas of this discussion using the following 3 bullet points. 1, I'm sure that this discussion will provide us opportunity to think through our early access to quality diagnosis for all. Early and quality and for all is extremely important, and the factor of time there is critical, as delayed diagnosis leads to unnecessarily suffering, increasing transmission of diseases, and of course, higher health care cost. The second consideration, which I saw in the program, which is really an exciting program, is the concept of patient-centered and also approaching it from an integrated service delivery. We all need to realize that integrated platforms actually enable us to optimize the scarce resources at our disposal, and it reduces duplication. Therefore, integration is really the way to go if we are actually all serious in increasing access and also ensuring universal health coverage. And of course, last but not the least, is strengthening resilient and sustainable health system is extremely crucial. Vertical program can only survive and deliver services if they are well aligned to a functional health system. Therefore, investing in multi-disease integration builds more efficient, adaptable, and people-centered health system. And therefore, collaboration between government, partners, and communities ensure that actually no one is left behind. Today's discussion should really move beyond identifying some of these challenges that are perceived to be synonymous to our Sub-Saharan Africa, but we must actually focus our discussion on practical, scalable solution and ensuring how health system can be strengthened to ensure accessible, high quality, and equitable healthcare to all. I hereby just welcome us all to enjoy the discussion. Over. Thanks.
Thank you, Dr. Guidado. I would like to introduce our next keynote speaker after I provide a short bio. Mr. Obert Kachuare works to support effective and efficient use of Global Fund resources for strengthening of laboratory systems and services and diagnostic products management. He is part of the Resilient Systems for Sustainable Health laboratory system strengthening team within the Global Fund Secretariat. He mainly supports high-impact Asia and Eastern Europe, Central Asia country teams. Previously, he worked for Integrated Quality Laboratory Services based in Lyon, France, as a senior lab specialist for 4 years, and prior to that, he was a senior program manager with TB and African Society for Laboratory Medicine. Without further ado, Obert, over to you.
Thank you, Gerard, and good afternoon, morning, and evening to you, colleagues. As my old friend Guidado has mentioned, to all of you, wherever you are. It's also an honor for me to be here with you today at this webinar on building a stronger health systems in Sub-Saharan Africa. This topic is very important to us because, as many of you are aware, in this current funding cycle, the Global Fund is strategically prioritizing a fundamental shift in service delivery to focus on integrated systems in a patient-centered manner. In addition, we have an explicit recognition of the role the partnership can and should play in pandemic preparedness and response. From this perspective, we have developed an integrated lab system roadmap that leverages previous Global Fund support to disease programs, which many of you have been part of in your respective countries. In practical terms for us, this means that lab systems integrations can work. Also, I have 3 bullet points, as Guidado had 3 bullet points. For us, it's patient-centric integration, which means routine screening for multiple symptoms. We also have our next generation market shaping team within our TB disease team. We are working towards this goal in collaboration with us, the lab team. Also, active case finding and integrated testing services. The second point is integration in technology, which involves multiplexing. As many of you are aware, we've been responsible to support a lot of integrated or networks like the Ilisari networks, bacterial and fungal infections, and also supporting core genomic function facilities, which of course are responsible for some of the metagenomics testing that has happened. Shared use of diagnostic platforms, including the NATs that are currently in use in many countries, PCR platforms that were used for COVID and that are now being used for TB, HIV, STIs, including the mpox responses, which we'll also hear about here. Genomics testing, which has also helped us to build capacity in wastewater surveillance, including COVID-19, as well as now TB sequencing. Also, in addition, dual target point of care RDTs, including the HIV syphilis duals, which were helping countries to improve. The third point for us is integration of lab systems. It means that a focus on human resources that are acting in an integrated manner in supporting our health systems, integrated sample transport networks, where we have clear examples of this in countries like Zimbabwe, the Philippines, and of course, lab information systems from countries like Indonesia and Mozambique, where we've also supported lab information system connectivity solutions, as well as integrated lab information system for public health labs. Support for quality management system across the different standards like ISO 15189, 17043, SLIPTA programs, LQSI-like programs, including RT-CQI approaches, including also inventory management, which caters for all lab commodities and equipment service and maintenance, capacitating biomedical engineers in country to support with cross-cutting skills all our labs that are involved in responses to the different diseases that are afflicting our continents. As well, of course, as advocating for all-inclusive pricing for our multi-disease testing platforms. We see this approach in investing in integrated lab system presenting a great opportunity to leverage the limited resources that you can all attest to in our current climate. We see this also leading to enhanced efficiencies and cost effectiveness, improving patient care and strengthening public health responses, and also driving innovation and promoting equity and access. Of course, it will, however, require continued and enhanced collaboration between governments, programs, technology companies, and funding agencies. And with these few remarks, I want to thank you and wish you all a successful deliberations. Thank you.
Thank you, Obert. I will first, before we move to our first country speaker, present a pie chart of the results of our survey that we had with you. So we had approximately 200 answers for this, and the vast majority said that integration of multi-disease testing has been implemented in your country settings. So 62%, 32% said they weren't sure, and 5.6% said no. So, so that's a good way to start for us. We are now going to ask you, as I mentioned in the opening, to put 1 or 2 words into the chat to describe what you consider enablers that facilitate the integration of multi-disease testing in your region or country. So we'll give you a couple of minutes to do that, and then I will move to the next speaker. Thank you. So I will start to introduce our next speaker. And as I mentioned, this speaker will speak about WHO's guidelines on multi-disease testing or integrated testing. So Dr. Jean Dedo Iragena works as the focal point for diagnostics for TB, HIV, hepatitis, and sexually transmitted infections within the communicable and non-communicable disease cluster at the WHO Regional Office for Africa, based in Brazzaville, Congo. He has been involved in the publication of WHO policies and guidelines on diagnostics and has coordinated their implementation at the country levels by interacting with member states and AFRO. Dr. Jean Dedo will set the stage for us today why it is critical to build stronger health systems through multi-disease integration in Africa. Dr. Jean Dedo, over to you, please.
Thank you very much, Gerard, for the introduction, and thank you for inviting me to talk about WHO guidelines on multi-disease testing or integrated testing. So next slide, please. I believe you will be controlling slides. Yes, as we are in the end TB strategy era, you might all remember this graph that shows the trends we would like to have. So what I would like to draw as the attention is where we are so far. We are in 2025, and we should question ourselves whether we really are using optimally the current and new tools that they become available from the pipeline. I mean that we need to think about whether we have been very successful to better use what we have, and we know that not many countries are using optimally what they have, and also we need to make sure that we have enough point of care so far as a test to really quick diagnose TB. So being in 2025 means that if we really want to end TB by 2035, we need to ensure that all those components, including new tools, including what we already have, are being used optimally. Next. So if you can go to next, please. Yes, we cannot really end TB without considering what we have. And WHO has developed a framework of lab indicators and targets. And those indicators and targets are very critical to really be followed and ensure that laboratory is addressing three main objectives. Number one is the increase of the access to rapid and accurate detection of tuberculosis. Number two is to reach universal access to drug susceptibility testing. And number three is to strengthen the quality of lab services. So this framework is a great document that really contains other considerations that need to be taken into account following those three objectives. The first one, of course, is to make sure that countries have diagnostic algorithm in place, and countries are using rapid diagnostic tests as initial for all the TB suspects, and also to make sure that the laboratory data are transmitted electronically to clinicians and also the patients. And we need to make sure that all the bacteriologically confirmed tuberculosis have drug susceptibility testing, at least for rifampicin. And we have seen that in the African region, for instance, we have 70% of those bacteriologically confirmed TB. However, we need to make sure that they undergo DST for rifampicin at least. And of course, on the top of that, those who are RIF resistant or MDR TB need to undergo second-line drugs. And we have seen this component as being really lagging behind because we are still missing a certain number, around 40% of those who cannot be used for DST second line. On the top of that, the quality is an area where the investment is needed in terms of the lab quality management systems towards the accreditation, and we do expect all the lab testing or implementing the quality assurance, and if really possible, at least the national TB reference labs can get accreditation. So this framework of indicators is really a Bible. All the countries should follow to meet those lab indicators and the targets. Next, please. Of course, not all the countries really have achieved meeting those indicators, but of course, this is due to some complexities of the lab network. As you can see on this slide, so far, WHO has recommended the use of molecular diagnostic tests because they are better in meeting the sensitivity and also in scaling up programmatic management and surveillance of drug resistance TB. Of course, they offer a speed of diagnosis and also standardized testing and they can be performed in a single working day and make lab results as soon as possible. And on the top of that, they can detect the presence of mutations associated with the drug resistant. However, the setting can meet some, let's say, some challenges in terms of the implementation. And on this slide, you can see that the central level, the intermediate, and the peripheral levels can implement one or another technology based on its complexity. So there are operational challenges molecular diagnostic technologies are meeting, and those challenges can be addressed in programs dealing with the different diseases, can combine efforts together in a way. This complexity of technologies and also the complexity of a setting can be discussed between the programs to better implement. Next. Of course, based on this complexity, we also need to look at the know-how to implement within the African region in particular, and of course worldwide. WHO TB supranational reference labs played a major role in the uptake in the rollout of diagnostic technologies, in mentoring the national reference laboratories in different countries, and in making sure that the uptake of technology is optimal. As you can see on this map, I would like to draw your attention on the number of the TB supranational reference labs we have worldwide. And you can look at the map of Africa, for instance, where we have a few labs. There are 4 so far, which are really helping countries to implement. And we do expect the other 2 that can join in the middle of this year, Rwanda and Mozambique, to support Lusophone and French and English-speaking countries. And also we are moving also to strengthening, I would say, what we call the National Center of Excellence for laboratories. And we have 2 candidates. One is located in Nigeria, in the National TB Reference Labs of Zaria. And we do expect to assess Zaria lab this year and make sure that this lab can be considered as a national center of excellence for the TB laboratory network in Nigeria. Another one is Ethiopia, EPHI, that will be assessed this year as well and join the network. So we do think that by the end of this year, we can have at least a network of 8 laboratories that can support countries in the uptake and the rollout. Without this, the know-how to implement can be a challenge for the countries. And we have seen positive results based on the regional-driven laboratory project led and conducted by the SRL Cotonou in Benin and the SRL Kampala in Uganda while they were supporting countries. So lab indicators and targets, you can even see from the global TB reports, any improvement you can see was really because of the support we got from the SRL network. So this is very important for us as far as even the integration is concerned. Next. So here is an example of the number of the SRLs we have, one in Nigeria, one in Benin, in Uganda, and South Africa. And as I said, by the end of this year, we will have at least eight labs, part of the SRL network, that will be really counted for the African region. So the areas of integration is very, very key. And integrating means that we need really to go through different phases, which are very challenging, I would say. If you look at the left side of my slide, you see the lab preparedness phase and the technology transfer and the routine testing, including the monitoring of a technology. So these different phases highlight the complexities of what needs to be done and we cannot be successful in integrating the diagnostics if we don't take into consideration those different phases. And one phase can last from 1 to 3 years. And from lab preparedness up to the routine testing, some countries might even take 5 to 9 years, depending on the technology and how the technology can be implemented. So going through these different phases requires a know-how to, and we do think that our TB supranational reference lab network is playing a major role now and in the future. Next, please. So we have the areas of diagnostic integration, and as you might know, from the endorsement of the gene expert in 2011 by WHO, we saw a great areas of opportunities for diagnostic integration. From the time the gene expert has been endorsed for TB, there have been other tests that have been endorsed by WHO, and they also pre-qualified, like experts for HIV, early infant diagnosis, and also hepatitis C, as well as HIV viral load, just to give you an example of some. For integration that need to be considered, because one machine or one equipment can be used to test multiple diseases, and experts has been really a breakthrough to open these areas of integration and showed that it is possible. I would like to tell you that on the continent, in the African region, we have around 8,000 gene expert equipment. So those equipments, once really they are, let's say, evaluated and the capacity is in place to test multiple diseases, those technologies can play a major role. There are the other areas of integration, like training site personnel, maintenance of those equipment, supply systems, referral system, and the quality assurance. All those areas of integration have results on the continent. I want to go through them. However, when there will be another opportunity, we can go through some results that can be shared globally about the areas of integration. So WHO published the notification about how to integrate in 2017, and this note is still valid and can guide the country on the better way to plan and implement multiple diseases testing using available devices on the continent. So this information is available on the web link I shared on my slide. Next slide, please. So WHO recommendations are really straightforward. We do encourage member states to use multi-disease platforms for testing of HIV, TB, hepatitis, and other diseases. I just highlighted those 3 diseases, but there are others like Mpox, like Ebola. I've been in one of the countries where Ebola was an outbreak, where I used really to connect let's say gene experts for TB, and that gene expert has been used for Ebola, for instance. So there are really opportunities, and we do encourage member states to look at those opportunities and plan accordingly. There is a benefit behind it, such as the increased system efficiencies, and also the improvements in terms of the access to testing, overcoming diagnosis and treatment challenges which are linked to the delay in testing. So those 2 recommendations are really straightforward, and we encourage countries to plan and implement accordingly. Next. So other opportunities are highlighting the collaboration. The collaboration is a key, especially now, as we all know. When you collaborate, you can increase efficiencies and share the costs which can be really conserving for the programs. The patient access means that there will be an increase in the access and improve the quality of care. As you know, one of the first objectives under the NTB strategy when lab is concerned is the access to diagnostics. So it's very crucial that the integration is taken into account. And national lab services, TB, HIV, and hepatitis program managers, maternal and child health programs, sexual and reproductive health programs, and also international and bilateral agencies are those really who can help member states to better plan, implement, and start measure the impact of the integration while supporting different diseases. Next. So this ends my presentation, and please, if there is any question, feel free to ask or to send me email. I'll be very pleased to respond. Thank you so much.
Thank you very much, Jean de Dieu, for the excellent presentation. We are now moving towards our first country speaker. After I give a short bio, he will talk about Mpox response in the Democratic Republic of Congo. So Dr. Justin Kinziangu Mawina works as the director and head of services of Health Laboratory Department in the Democratic Republic of Congo, and he's an active member of the African Society of Laboratory Medicine. He holds a Master of Public Health and a Master of Science in Field Epidemiology. He's also studied laboratory technology and medical biology in the Institut Supérieur de Technique Médicale in Kinshasa, DRC. Dr. Justin will share the story about how the DRC has been managing Mpox outbreaks in the country, utilizing existing laboratory systems and resources, and what were lessons learned, and as well as barriers and challenges in that effort. So as a reminder, Dr. Justin will present his slides are translated into English. He will speak in French, and there will be a brief synopsis of each of his slides after he speaks. Over to you, Dr. Justin.
Ok, merci beaucoup. Hein? Bonjour à tous. Il m'a été demandé de pouvoir un peu de présenter rapidement la situation de la RDC. Voici l'économie de ce que nous avons pu préparer pour échanger par rapport à notre expérience en termes de réponses en rapport avec le Mpox DIA. Nous avons prévu dans notre agenda quelques points essentiels à présenter. C'est en rapport avec la situation épidémiologique, les challenges, les leçons donc apprises, et nous allons terminer par une petite conclusion en rapport avec ça.
So Dr. Justin is going to take you through the epidemiology quickly on DRC, as well as the country context in diagnosis, as well as the role of gene expert, the challenges that the country is currently undergoing, and the lesson learned through that process, and he will finish by a conclusion. Thank you. Next slide.
Okay. En rapport avec la 10e semaine épidémiologique, donc 2025, nous avons les nouveaux cas notifiés 2183 contre 2138 sur la dernière semaine, dans la 9e semaine. Et parmi les nouveaux cas confirmés, il y a au moins 150 cas confirmés par rapport à 179 par rapport à la semaine 8. Donc, et aussi en rapport avec les nouveaux décès. Parmi les cas confirmés, il y a 3 décès contre 5. Et par rapport aussi à la couverture en termes de testing, il y a au moins 21 sur les 26 provinces qui rapportent en termes de rapportage, en termes de provinces. Et voilà un peu les essentiels par rapport à la situation épidémiologique.
So a brief summary of what Dr. Justin explained on the epidemiological side. The number of cases, notified cases, is over 2,000 cases and has been slightly increasing. The new cases are decreasing a little bit, and the number of deaths have been reduced a little bit. More importantly, regions that are capable to report coverage of Mpox outbreak currently are 21 regions out of the 26, which is a progress at this week number 10. Next slide.
Oui, en termes de décentralisation, donc nous tenons d'abord à remercier son Excellence le ministre de la Santé publique, Hygiène et Prévention sociale par rapport aux efforts qu'il est en train de mettre avec l'Institut national de santé publique en termes de réponse directe, en termes de réponse Mpox. Mais essentiellement sur le 26 provinces, nous avons capitalisé le DIN-Expert qui sont implémentés dans les 26 provinces, à partir dont nous avons identifié 211 DIN-Experts qui sont accessibles. Sur les 200, donc actuellement, nous avons 15 sites faisant des diagnostics Mpox avec DIN-Expert et nous avons au moins 55 sites que nous devons essayer un peu de pouvoir intégrer les diagnostics en termes d'Mpox.
Voilà. Rapid translation here. This map shows the decentralization of laboratories in the 26th region and where GeneXpert has been utilized for Mpox outbreak in particular. From the database, there is about over 200 GeneXpert that potentially could be used, and 15 GeneXperts are currently already doing the Mpox test with the wish of expanding to 55 sites that have been wisely selected for the Mpox integration within the tuberculosis program. Over to you, Dr. Justin, for the next slide.
OK, merci beaucoup. Donc, sur les 555 plutôt GeneXperts sélectionnés pour le paramétrage Mpox, nous avons tenu compte de l'accessibilité dans les zones de santé desservies et avec des infrastructures routières existantes et aussi entre Kinshasa et les provinces du nord du Sud Kivu. Il y a un peu de rupture en termes de la situation sécuritaire. Il y a les zones qui sont à une forte incidence, Mpox, et il y a aussi en termes de plateaux techniques, donc de laboratoires qui disposent des équipements, et en termes aussi de sources d'électrique, de l'électricité que nous avons pu capitaliser, et aussi en termes de compétences identifiées avec de personnel. Voilà un peu le critère de sélection avec pour l'extension de ce DIN-Expert dans les 55 sites que nous avons pu identifier.
Dr. Justin was just explaining on this map the plans where they are thinking to expand the Mpox testing integration on the GeneXpert. Out of those 55 GeneXpert, they had specific criteria, and actually they have 5 criteria. Number 1 being the accessibility in the areas that are served in with existing infrastructure, given the situation with the war and the roads that have been disrupted between Kinshasa and the South Kivu, which is the region more at risk currently. There is also the second criteria was around the incidence rate of the Mpox, particularly where there's an increased epidemic risk. The third criteria for the selection is the technical platform, so where there is availability of equipments, typically freezers and other type of equipments that might be required. And the fourth one is about the electric current source, making sure that the electricity is absolutely functional to make sure that the gene expert can operate without any issue, and ensure staff competencies. So these are the 5 criteria utilized to select the sites to do Mpox testing integration. Next slide.
Oui, en termes de leçons, leçons apprises, donc nous avons vraiment la formation continue et rapide, donc à travers les sites qu'on a pu identifier, à travers les gene experts qui existent, et nous avons le renforcement des équipes locales pour la gestion et la coordination et l'intégration, donc d'une façon optimale. Et nous avons aussi des capacités privilégiées en termes d'optimisation des testing et aussi en termes de les échantillons qui arrivent selon les investigations sur le terrain. Donc, il y a aussi le gene expert qui donne, qui sont disponibles pour essayer un peu de prendre en charge la situation. Il y a aussi comme conséquence, bon, il faut vraiment rationaliser, donc les équipes, il faut toujours gérer les problèmes de charge horaire en termes de multiplex. Et il y a aussi l'accessibilité très lointaine à des zones à risque, donc comme difficulté. Et il y a aussi cette problématique de l'insécurité. Voilà un peu les essentiels par rapport aux leçons apprises par rapport à cette expérience de la République démocratique du Congo.
In summary, so the lesson learned from Dr. Justin and program in DRC was it was important to have qualified staff, so they invested in training and education. With continuous education, they have implemented referent persons to strengthen the local teams for management and coordination of the Mpox testing within the National Tuberculosis Program. Then the second points were around how important it was required to prioritize the diagnostics for emergencies. So within the TB program, they have made sure they optimize testing capacity, focusing on expert Mpox test in this case, and making sure that sample arriving would be prioritized over TB, and gene expert must be available for emergencies anytime it's needed. There's been some work ongoing also to modify the algorithm to optimize it and make sure that integration is part of it. Few impacts for the diagnostic of tuberculosis. Of course, gene expert was primarily here for tuberculosis, but it has required to rationalize sample management to better manage the increased workload of the staff in this particular emergency situation, and work with specific differentiation in terms of sample being collected. Final point is about the accessibility. So the areas where there are risks, in particular, given the conflict areas, have been more difficult to obtain the cartridges, and difficulty in doing the preventative maintenance of the devices. Over to Dr. Justin.
Yes. En ce qui concerne aussi les défis des tests au niveau de, vous voyez, les problèmes est de paramétrage, paramétrer les gene experts, et avec aussi comme difficulté avec les kits PCR. Vous savez qu'il y a des provinces, la ville-province de Kinshasa et le Nord Kivu à travers Goma qui ont des tests PCR. Il y a aussi les problèmes seulement des transports des échantillons qui posent des problèmes très, très réels, vous voyez, en termes de collecte, en termes de transfert, la couverture de testing qui passe de 16%. Donc, ce sont des problèmes vraiment réels hein, par rapport au transport et aussi en termes de paramétrage de ces 10 experts, parce que nous avons identifié les 10 experts à travers le 26 provinces, selon les statistiques que nous avons pu donner. Maintenant, ça nous aide à pouvoir intégrer les diagnostics petit à petit.
So the key message from Dr. Justin here is there's been challenges in lab testing in the RC, and in particular, you would see the graph here showing the complexity related to two major factors. Number one being the complexity for setting up the integrated testing, including the mpox test within the TB program, and the second one being the transportation difficulty. Transportation is a major problem given the current situation in the RC with the conflicts ongoing. Next slide.
En termes de conclusion, vraiment, donc, le pays a vraiment capitalisé comme des avantages le DIN-Expert. Donc, d'abord, en termes des avantages, il y a disponibilité de plusieurs, d'abord des outils DIN-Expert qui sont à travers le 26 provinces. Ça, c'est comme facile à être utilisé dans des sites ruraux, urbaino-ruraux. Et aussi, il y a cette facilité de trouver ces kits-là qui sont à travers le 26 provinces. Ça, ce sont des avantages par rapport à l'outil X-Expert, donc DIN-Expert. Comme les choses à améliorer, hein, donc c'est la non-détection dans des zones à forte densité de CLED, hein, des CLED, CLED 1, donc, et aussi en cas de résultat orthopox non valide, donc là, ça nécessite qu'on puisse les faire comparer avec les kits PCR, les autres PCR qu'on pouvait. Voilà un peu, donc les petits, mais c'est l'outil qui est quand même capitalisé, qui est important pour essayer un peu de nous aider à pouvoir avancer au niveau de la République démocratique du Congo. Donc voilà, donc ça nous aide vraiment à pouvoir, là où qu'on n'a pas de l'accessibilité facile, on peut à travers poser des diagnostics à bon escient. Voilà un peu d'une façon globale en termes de conclusion. Merci.
So in summary, Dr. Justin was mentioning that the DIN-Expert is a tool that is critical to help diagnosis in the RC, and the country has really capitalized from the advantages of the DIN-Expert, not only for tuberculosis, but also now for the mpox. Part of the benefits and the advantages, he has noted specifically the availability of the DIN-Expert already present within the National TB Control Program in the RC across the 26 provinces, which simplifies, of course, the decisions and the processes, but also the fact that the process is simplified and very easy with the DIN-Expert. Now, the key consideration to improve is about in areas where there is a high incidence of clade 1, that there is a little more work that needs to be done with additional testing that needs to be complemented, given that the test result is focused on clade 2 and non-variola orthopox currently. But overall, I think Dr. Justin was positive. I think we are at the end.
Okay, merci beaucoup, Dr. Justin, and thank you, Indira, for translating so well. We are now moving to our another word in the chat exercise. We again want you to put 1 or 2 words into the chat about what are the challenges that hinder the integration of multi-disease testing in your region or country. And to make up for some time, I'm going to move quickly to introduce our next speaker while you're doing that. And we encourage you to put in the Q&A throughout this webinar. We have 30 minutes approximately remaining. Any questions or comments or suggestions that you have into the Q&A for us. Thank you. So the next speaker is Professor Moses Joloba. He's an infectious disease expert with a focus on pathogenesis, diagnosis, and program implementation, using both conventional microbiological and modern molecular approaches. He was appointed director of the National TB Reference Laboratory, which is now a supranational reference laboratory. The NTRL is internationally accredited and supports 1,300 laboratories in Uganda and 18 national TB reference laboratories in other sub-Saharan countries. He has also pioneered a TB sample referral system that has now been integrated to transport specimens for other diseases beyond tuberculosis. As Uganda is one of the spearheading countries in multi-disease integration, we are delighted to invite Professor Joloba to talk through Uganda's journey. Professor Joloba, over to you.
Thank you very much for that kind introduction, and I hope you can hear me. My presentation is about best practices, addressing public health issues using gene expert systems in Uganda. Okay, the laboratory and diagnostic services in Uganda are under the National Health Laboratory and Diagnostic Services, which is headed by a commissioner here, Dr. Susan Navada. What you see here is the Central Public Health Laboratory in Butabika, Kampala. Next slide. So the National Health Laboratory and Diagnostic Services is an integrated tiered laboratory and diagnostic network. You have university labs, national reference lab, animal health labs, and a regulatory framework, which goes down the grassroots. The NTRL is also part of that, Central Public Health Laboratory, a National Equipment Calibration Center, and a Quality Assurance Laboratory. Next slide. So, as already introduced, Uganda pioneered an integrated sample referral system, which is based on a hub and spoke model. Samples move from the periphery lab, the PL, to the hub. And the hub is an enhanced lab where advanced techniques are included. And here in the hub, all hubs in Uganda have a gene expert machine. And when it is tested, complicated samples, for example, those with resistance, are sent to the reference lab for further testing. Next slide. So again, this exemplifies the sample referral system. On the map shows the map showing the hubs across the whole country, well situated, and they are placed according to the need. And in that circle, you could see a network of which is served by the lab, by the hub. Samples move from the health center, health facility by motorcycle to the hub, and then from the hub using cars to the reference lab, which is either Central Public Health Laboratory, NTRL, SRLs, and other labs. And down there, you could see that from health facility, to the samples moving on a motorcycle, which are able to navigate bad roads, particularly whether it's dusty, potholes, or rain. And then the cars move from the hub to the reference lab, and these are quality assured laboratories, which therefore means there is access to quality assured testing. In a year, the sample referral system now carries 3.5 million samples of different types: HIV, ID, TB expert, CD4MR, even outbreaks, COVID, Ebola, measles, polio, cancer, animal health. EQA panels also move, and logistics for sample collection, equipment maintenance and calibration, environmental samples. Next slide. So on the left panel here, you could see the distribution of molecular WHO recommended diagnostics, which includes GeneXpert. They are distributed according to a well-designed network assessment. On the right, you can see the hub and the spokes. There are 100 hubs and 2,454 spokes in this reference, in this network, which means it ensures accessibility to testing. Next slide. And the vehicles move also. The vehicle movement are mapped and scheduled. And you can see on the right, they even in that stars, they reach veterinary labs to collect samples when needed. And then they are moved to the center. Next. Laboratory quality management systems has been incorporated in this network. Labs are being accredited, and you see the quality management system is integrated. When these labs down there are integrated, so every test is included in there. Next. So Uganda has embraced a quality assurance system, and you could note it started with actually standalone labs in 2010 and research labs, but has been accelerated over time. So in 2015, the supranational reference lab, which is the TB lab, was the first public health lab to get accredited. But then it paved the way. In 2020, you see 21 labs. In 2023, 71 labs. And this trend is completely increasing, and we are currently looking at establishing an accreditation center. And we have certified SLIPTA auditors who go through a SLIPTA process. Next slide. So these programs are using GeneXpert systems. So far, we have many GeneXpert, but 153 expert facilities are integrating TB with other diseases, such as HIV, early infant diagnosis, HIV viral load, human papillomavirus, and COVID-19. We are piloting for STIs and hepatitis B. Next. So this, okay, yeah, we're going a little bit fast, but it's okay that we could go that. The data here shows the testing for TB, which is over 105% utilization, but others are also picking up HPV, HIV viral load, HIV EID. Next. So this is a GeneXpert Access Care program, which we work out with SafeAid, and it shows because equipment maintenance for GeneXpert has been a big challenge in this region, but with bundling, where we add on a markup price to the cartridge, we have really hammered out a very good system. And with 776 instruments, 1,652 modules, and we have achieved a 99.92% availability of machines and 99.75% availability of modules at any one time. So we negotiated a very good deal with SafeAid, and we have a connectivity solution which is monitoring whether these indicators are being done, and it's a timely critical path. Information flows very, very fast. So we have kept most of our machines functional, and there is a lot of good preventive maintenance. this is very encouraging. Next slide. And of course, that access to care program is available not for TB only, but also for other diseases. So this is the connectivity solution I've been talking about. We are very grateful to CEPHID for allowing us use a local solution, access data, transmit it. It doesn't not only transmit GeneXpert, it transmits TrueNAT, Aphion, PIMA, X-ray, Digital X-ray, and we are continuing to add on more equipment. The data connectivity transmits all data, HIV, TB, EID, and HPV. They are transmitted across the network. So this has been a local invention from Uganda, and it really has been helpful. Next. So the lab expert, it really returns data in real time to the patient and a text, but also to the clinician in real time as the results become available, and also to a dashboard. This is a dream come true, and of course you can see even an app, so that you could really look at various data, functionality of the machine, results, a lot. Next slide. So this multi-disease testing has a lot of advantages. It improves access to diagnostic services for more diseases, a shared maintenance cost, which definitely lowers cost for one program, is cost effective, no need for many machines. You really have one machine to do all diseases, so you spare lab space. There is increase in equipment utility. This issue of equipment is redundant, is not an issue. And for low capacity building costs, you really train one person, does many things. Efficiency in specimen referral system. One sample referral system brings many things. Is the data management, one transmission. So is also to maintain. So there are a lot of pros, but there are cons also. We have few machines for the job, and people are really selfish in the program. Not all disease programs will contribute to buying machines, but they want to use. And of course, we are not very happy with CEPHID machine placement plan, which is not readily available. It's very complicated to negotiate. And of course, a priority bias toward certain tests of diseases. People are more likely to do other tests than others. Of course, being a TB person, my sample is not a preferred sample many times. Next slide. So increase, of course, in turnaround time due to increased workload if you have very many samples. Next. So in terms of best practices, we are trying to develop, and we have developed, and we are using a multi-disease testing guideline. So we prioritize diagnostic tests versus treatment monitoring. For example, if there is an EID sample and mother has given birth, is living, we do that first, or a TB diagnostic vis-a-vis a viral load. So that is a best practice we have adopted. And the data connectivity, as I've said, is a wonderful innovation, enables integrated data management, real time, no transcription errors. We can go on and on for that, but very wonderful best practices. And monitoring utilization by disease programs. With one data connectivity, we can really send data to various programs. They can then linkage to patient care is much easier. And of course, integrated support supervision. One support supervision caters for many diseases. Thank you very much. I think I get the final slide. Asante sana. Thank you.
Asante sana, Professor Jolob, a very impressive presentation. Thank you. We are going to now move to the next speaker. I am going to first introduce his bio. Mr. Christopher Aymanre is a strategic healthcare professional who delivers impactful outcomes in public health, clinical research, and healthcare management. As a technical advisor at the KNCV Tuberculosis Foundation in Nigeria, he provides strategic leadership on the CEPHID GeneXpert project. He leads complex initiatives, optimizes operations, and ensures regulatory compliance. Christopher has helped the country's program to build the sustainable health systems at the remote settings to bring testing nearer to the patients, so more point of care and patient-centered. Today, he will share us from A to Z about the power dynamics in terms of electricity and the introduction of solar panel implementation in Nigeria. Over to you, Chris. Thank you.
Thank you very much, Gerard. The way you pronounced my last name, I'm sure you could actually pass for a Nigeria with Edo and Ishan ancestry. You did a great job anyway. Yeah, good afternoon to you all from Abuja, Nigeria, and then thank you for joining us. I'm excited to share this presentation titled From Black Arts to Bright Futures, a Shared Pathway to Reliable Healthcare Power Across Nigeria. This topic became imperative due to the erratic power supply being experienced in Nigeria. And this power cut, makes diagnosis of TB and other diseases difficult using the GeneSpart machine, which is a multi-disease platform from what we have heard from, the previous speakers. And then it's rely on a stable power from electricity grid to batteries or alternative sources to be able to power the system. As we all know, the GeneSpart was adopted in Nigeria as the first line diagnostic tool after it was endorsed by WHO in 2010. And then most microscopy sites were replaced by the platform in health facilities where it was installed. We had fewer numbers of GeneSpart machines in the early years to more than 540 installed base as at 2014, placed in different levels of the laboratory, peripheral, central, peripheral, and remote setting. KNCV partners in implementation of GeneSpart for integrated testing of TB, HIV, and other test menus ranging from reproductive health, sexual health, oncology, and genetics, as well as emerging diseases, just to mention a few. And all these machines are being maintained by KNCV team, being the authorized service provider since 2014. So as a country, we share our journey for a stable power source for the GeneSpart laboratories. So the question, might pop up, why the need for a backup plan? Like I mentioned earlier, Nigeria is challenged with erratic power supply, which are not readily available in most health facilities, making diagnostics of TB and other integrated testing difficult using the GeneSpart machine as it requires stable power for optimal use. But TB laboratories open from 8 a.m. to 4 p.m., roughly 8 hours on weekdays, and a little less during the weekend. And there are a few others that actually get to run, around the clock. But there comes the power cut. With the power cut, it means that, there's no power to power the GeneSpart machine because of, the erratic power supply in country, which makes it start daunting. So with sample regularly delivered to the laboratories, without stable power, sometimes there are backlog testing, which, will take a prolonged, which will take time to actually get to mop it up if there are prolonged outages with this sample. And then oftentimes these samples can go bad. So the country's average power availability, it's about 6 hours a day, although 80% of hospitals rely on petrol and diesel generator as a backup and power supply. But fueling, it's a real major challenge. They are not readily available. And then generators run at regimented time, due to varying factors in all of these facilities. If we take a closer look at the average power supply for laboratories for household in Nigeria, we could see that 68% gets power between 1 to 9 hours, and then you have 5% of population that are in perpetual darkness that don't get power at all, and then just 1% of the population get 24 hours. So you can see that this is a real challenge. you know, it's there's a saying in Nigeria, there are two things that bind us together. When our national team are actually playing football like they did yesterday, you know, when they score a goal, you can hear everybody, you know, with a resounding goal. And at the same time, when there are power outages, and then the powers are being restored, you get to hear everybody shouting at the same time, up NEPA, up NEPA. So this is, you know, has been a challenge in country. And then, yeah, that's why we actually, you know, looking out for ways to fix them. So the evolution of our power source, being from PHCN, the Power Holding Company of Nigeria, which is the primary source of power that's not reliable. And then we moved to uninterrupted power supply, having UPS to make up for those times. And then, yeah, some generators in some facilities, yeah, to help cushion the effects of the non-availability of power. And then, yeah, the inverter and the solar system, which was of recent, you know, introduced to actually get to enhance all of this power. In some facilities, you have up to about 3 power sources, you know, combined together that helps, yeah, these GeneSpart laboratories to function effectively. While in some, yeah, few in number that just have the national grid, but yeah, most of those facilities are actually in the remote settings. So around 2014 to 2018, yeah, the country was using the uninterrupted power supply, which is the UPS. It provided a backup for at least, you know, for the test to run within the time frame of about 2 hours. And then they are very, very, very cheap. And then they are the easiest to install. You know, you just plug the GeneSpart machine, you know, directly to the UPS, and then it goes into the power source. But, you know, regular maintenance ranges from just, you know, minor changing of fuses or the battery. But this alone, yeah, was not sufficient to actually get to, you know, run an effective system. In that the UPS only powers the GeneSpart machine and the computer, and then the air conditioning that was supposed to actually get to make the system, you know, cool and work effectively were not there. So this leads to heater malfunction, yeah, in the GeneSpart. And as the battery grew weak, yeah, there's lots of samples, yeah, which actually give quite a number of error results, and oftentimes no results, as the case may be. Next slide, please. And yeah, we have the petrol diesel generators. They are readily available in most facility, and they come in different sizes, which allows for choice of fonts that are available. As you can see in this picture, we have yeah, the bigger Lister generators that uses diesel, and then we have, you know, other sizes of a generator, even a smaller one. In Nigeria parlance, we refer to this as a better pass my neighbor. In low settings where, you know, you have a complete blackout. So if a neighbor is able to get this generator, you know, he sees himself as a big man. But funny enough, this same I better pass my neighbor generator actually works in most facilities. There are some facilities in, you know, remote areas that actually depend on generators as small as I better pass my neighbor for them to actually get to function. But usually, yeah, there's need for power shedding in most facilities. In that, yeah, there could be need for power to be, you know, sectioned to a particular part of the clinic, and thereby the diagnostic aspect of the clinic suffers. And then there's, you know, the changeover from national grid to the generator. It has to be seamless, so as there's no cuts in power. And then this, of course, will actually get to lead to double cost, whereby, you know, you're having generator and UPS at the same time. Fueling and maintenance are quite expensive at the moment. You know, buying fuel in Nigeria, it's really, really expensive. And then there's pollution, yeah, where you have fumes and smoke that are being produced by these generators. If that's also, yeah, it's a minus, yeah, with the use of the generators. Next slide, John. And in 2016, 2019, yeah, we moved to the electric inverters. Well, we say the electric inverters, yeah, they actually rely on either the generators that are available in the facility or the national grid to actually get to charge them. So they could last as long as the power bank holds charge. But since the national grid was not reliable, so, we are back to the empty power bank issues. So they couldn't power the accessories also, the ACs and the refrigerators. And then that's prompted a lot of modular problems also, leading to error 1001, error 102, error 4010. These are all the errors associated with the heating component of the GNSPAT system. And then oftentimes sample goes bad in cases of prolonged power outages in this facility. Next slide, Jim. Then we have the high capacity solar inverters, which in 2021 and to date, that is used, that is quite reliable. And then this solar high capacity solar inverter and batteries harness energy from the sun, which is readily available in most parts of the country. Yeah, it's clean energy, and it's an upgrade, of the UPS and electrical inverters. And charging of this battery, it's gotten from the sun. Like I mentioned earlier, they are, available, in most parts of the country. And then, this leads to reduction in electricity bills. And then it comes with a low maintenance cost. Oftentimes, it's during the dry season where you have a dust pallets hanging on the solar panels, and you just need to maybe mop them up as well, and then you are up and running again. But on the downside, they are weather dependent. We have a large vast of land that has direct sunlight in the northern part of the country. But when you come down to the southern parts of the country, where you have the rainforest, the weather sets in there. So you need to actually get to condensed power, or you combine this power source with the national grid or the generator, as the case may be. And then at installation, they are really, really expensive in that they are high capacity solar panels and batteries. And then they require a lot of space. As you can see in this picture, this is a wild truck that has the solar panel. It runs completely on the high capacity solar panels. It has all the batteries inside, and then they move from one community to another, providing diagnostic services. This slide is just giving us an overview of what the specification, having an average high power solar inverter setup. The sun actually gives energy to the heat up the solar panels, and then they conserve energy, with the charge controllers, and then that's actually store power in the battery banks. And then when the load is engaged, so the battery banks actually get to give out this current that has been stored in there. And for the ratings, with 4 kVA of about 24 volts or 48 volts, pure sine wave inverters, this could actually get to do. And then in country, we are using the deep cycle batteries, although the lithium batteries seem to be more durable. I think moving forward in the next chapter of power optimization in country, the program is actually looking at using lithium batteries, being that they are very much durable in giving out these power energies. And warranty covers for about 5 years on each of these items. Next slide, John. So this gives us an overview of where we have the optimized high capacity solar system in country as well. If not about 90 to 95% of the GNSPAT sites currently are being optimized, as you can see in the diagram. Next slide, John. So this is just a picture, to give us all of the power source, the solar panels, as you can see from the wild truck. The wild truck houses a GNSPAT machine, which is actually a good source of integration, in that they move from community to community out to reach areas, with the GNSPAT machine in it, testing for TB, HIV. During the COVID outbreak, the wild truck came handy. They were moving from community, to community as well, getting people tested. You have the solar panel on top of the truck, and then you have the other accessories, inside the truck. And our friend here, the Better Pass My Neighbor generator I talked about earlier, that too could actually get to help. And then there is a backup, like the way you have the wild truck. yeah, you have a power generator as well. It could be attached to it. Maybe when they move towards the southern part of the country where there are no large amount of sunlight, yeah, they could actually get to use the they could use the generator to power up the batteries, yeah, for them to have an optimal use. Next slide, please. And all of these power sources come with their own challenges as well. We have a lack of funding, who pays for all of these installation. And then there you have the natural disaster, insecurity, logistic issue. If you look at the picture to the top right, you can get to see a whole community was submerged in water. This happened a few years ago, where you have a community that's actually at the gateway between the northern part of the country to the southern part of the country was overflooded. There was no movement of goods. There was no movement of reagent. There was no movement of commodities. And then this actually, set the country back in terms of, testing. And if you look at this other picture, you have a facility that was completely submerged in water. By the way, that's a GeneSpot machine. You get to see there. So these are challenges as well. You have power problems, faulty inverters. There are the storm hits the inverters, they go bad, and then you have some installations that are not properly done. Maybe the earthing or the lightning control were not properly connected, and then this could actually get to affect and then poses a setback. And there's the issue of vandalism too. When you have civil unrest, like we had protests in the past, and then some non-state actors actually hijacked the protest and then use it as an opportunity to vandalize and loot some of this infrastructure. So these are, the challenges being faced. But what are the considerations when setting up these high capacity solar panel inverter batteries? All the power source considered add maintenance costs attached to them, and then plans should always be considered to cover costs of occasional repair, which are not always covered by the warranties. And then capacity building for facility engineers should be factored in that, time to time, they might need to come and carry out maintenance in these installations. And then all of these backup were actually donor funded from USAID, PEPFAR, and the Global Fund. Next slide, June. So as a country, what are the lessons we have learned? It is imperative to know that uninterrupted availability of power for medical laboratories is vital to the success of diagnosis. And then as a country, there was a 51% increase in diagnostic testing after the power optimization exercise was carried out. And then sustainability of any power source needs to be budgeted for. And of course, with stable power, you have your turnaround time results, being effectively given out. I will always say, next slide, John. I will always say, we never stop trying. It gets better. I would want to acknowledge our funders, the federal government of Nigeria, Global Fund, USAID, PEPFAR, a colleague from KNCV, TB Plus in the Hague, and in Nigeria, my project director, especially Ms. Priska Ajiboye, for taking our time to help out with this presentation, and for our colleagues at CEFID and the National TB Leprosy Control Program and the National Technical Working Group. Thank you, thank you, thank you.
Thank you very much, Chris, for the fantastic presentation, and congratulations on that, rolling that out. We are going to present now the word cloud briefly, and then we are running out of time, but I will try to answer a question. There's another question from Nigeria about mechanisms to encourage countries to increase the number of integrated testing sites. And I think Obert mentioned that one carrot and stick for that is with Global Fund, that they really encourage that. And it's also, as Guidado mentioned, more cost-effective and more patient-centered, and it actually saves cost if you diagnose effectively and quickly and put people on the appropriate treatment. So the enablers, the bigger letters, political will was the most common comment about enabler. and then training after that, and then sustainable funding after that, and then you can see all the other smaller ones. So that's the word cloud for enablers. Can you show the next one, please? And then in terms of challenges, the largest challenge, common challenge, was insufficient funding, and then political resistance and technical know-how, limited priority and number of gene expert instruments in the site, and then smaller ones. So I would just like to quickly conclude thanking the wealth of experiences presented here from our representatives from WHO, from KNCV, from the countries. I think we've shared our learnings and our experiences. I think that one thing that we've learned is that there are opportunities to use the existing network to add on other diseases and integrate and make systems more resilient. And the example from the DRC about integrating mpox when it was needed is very important. And COVID was integrated. It was mentioned by Moses, and other diseases, and the network, the transport network, and the integrated system for reporting and diseases, and the SMS technology that was homegrown in Uganda was very impressive. We also learned that solar energy can be an effective and cost-effective use in countries, especially where Africa has a lot of sun, and also a lot of problems with electricity grids in a lot of places. We also learned that there were trade-offs with integrated testing, and that you have to adapt algorithms, staffing, hours, and prioritize potentially diagnostic over treatment monitoring was best practice that was mentioned by Professor Jaloba. And I will stop there, and I want to thank everyone for your participation.